Okay, everyone. Thank you so much for joining us today and welcome. It's just after 12, so we're just going to go ahead and get started. Today's webinar is on substance use disorder and medication for opioid use disorder in our communities. Break the stigma to break the cycle. Our presenter is Katrina Suarez, peer recovery educator with the Michigan Opioid Collaborative, and I will be introducing her in just a few minutes. Before getting started today, please make sure you're muted if you're presenting or sharing. If you have any questions, please post them in the chat. We will address them at the end of the presentation. If you haven't already, please sign into the chat with your name, email address, and organization name. If your Zoom does not have your full name, we can't always identify you and rely on your sign in the chat, so we appreciate that. Thank you. A PDF with instructions and links for obtaining credits for today's webinar will be posted here in the chat a couple of times throughout the webinar. We offer CME credits for medical professionals, CEU credits for social workers, and McBAP credits. At this time, we have not received approval for the peer-specific credit. We will be sending all attendees a certificate of attendance after the webinar today. If we get approval for the peer-specific credit, we will send an email with the necessary information to obtain the credit retroactively. The links to obtain credits will expire within 48 hours, so please make sure you complete this process for getting your credits by Friday, August 18th at 12 p.m. You will also receive an email a couple of hours after the completion of this webinar with instructions for obtaining credits, as well as a certificate of attendance. Your regional BHC, behavioral health consultant, will email you later with the slides for today's presentation. I'm going to give a quick overview of the Michigan Opioid Collaborative. The Michigan Opioid Collaborative is an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. Oh, I'm sorry. Sorry about that. Can everybody see my screen? Thank you. Yes. MOC is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day patient consultations to help providers. We provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders. The MOC offers quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics, such as addiction, stigma, and substance use topics. We have a hepatologist on our team who offers hepatitis C treatment consultation within 48 hours, facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on hepatitis C treatment. We've also created toolkits for providers to have more resources when treating patients with multiple substance use disorders. These toolkits and most of our resources can be found on our website, which we'll post in the chat here in just a second. With that, I'm going to go ahead and introduce Katrina. So Katrina Suarez is our speaker. She's a certified peer recovery coach. Katrina attended the MDHHS Certified Peer Recovery Coach Training in 2020 and has been in long-term recovery going on 9 years in November 2023. She has worked in various recovery settings as a peer recovery coach, such as the Opioid Health Home with Hegra Health. She worked in their relapse prevention program and led multiple groups a day in their inpatient treatment facility in Oakdale. She then went on to be a youth peer program manager for Detroit Recovery Project. And once that programming was in place, she became certified in HIV and hepatitis C testing and counseling and worked for the Needle Exchange program. With that, I'll turn it over to you, Katrina, to go ahead and share your screen.
Hi, everyone. My name is Katrina. Sorry if my voice gets a little hoarse. I do have some water with me. Let me go ahead and get this into the view I need it to be. And we will get going. All right, so we're going to get into this by first discussing how this is a chronic medical disease. Those living with an SUD, as we all know, this is not something that we came into this ever thinking was going to be called a chronic medical disease. We've gone through a lot of debate over this. We've definitely have had to go through years and years of trial and error, but now we're at the point where we are able to definitively know with all the data that's out there that this is a chronic disease. So we're going to define addiction. Addiction is a primary, sorry, I got to move a couple of things. Let me get out of this view here that I've got everybody up. There we go. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. We know that, when we make something routine, then that becomes our routine. We know that when we're speaking in terms of circuitry, we get so used of feeding our addiction that's how our body responds. That's the only way we're going to get a response out of our body. So next one, definition of it. Addiction is characterized by inability to consistently abstain. That's part of the whole, the reward response that we get when we're in our active addiction. Impairment in behavior control. That's all those behaviors that come with it, all those things that come to surface when we are out there just trying to survive one day after the other. Craving or increased hunger for drug or rewarding experience, diminished recognition of one's behavior and impact on self and others. Dysfunction, there we go. Dysfunction and emotional response. The emotional response we know gets stunted at a certain point. There's plenty of evidence out there that shows once we get back into trying to live our lives, even our reactions are still, stuck in that moment when we first started, whether we were 12 or 13. Just our ability to really progress in life and just learn from our experiences and things like that, and taking everything in so that you can respond to most behaviors in a way that the community would deem appropriate. So we're going to take a closer look at the numbers. When we sent out the survey, 59 individuals responded, and we've got a total of 5 regions. A lot of these graphs are going to reflect the response rate in these regions and just how our surveys felt was going on in their specific region. So this isn't anywhere as a whole. And when you look at the numbers, if you just kind of keep in mind, like, is this a rural area? Is this an urban area? Like, what kind of area is this? That could have a lot of impact on, how the numbers look. And look at how many respondents know someone struggling with an OUD. 92% has responded that they know somebody, or they've got a friend or a family member encompassed that. So 59 people, 92%, that's most of us. And that's pretty typical with what the landscape looks like all throughout America. We know that there's about 46% of Americans that are struggling with addiction. We know that like 7.5 million children have at least one parent that is struggling with addiction. And with 7.5, I think that makes it somewhere around like 10% or something like that. So the numbers are pretty high. And when we look at the drug overdose deaths per year, in 2020, the last numbers that were taken is over 100,000. In the past, I think it's been 18 months, we have surpassed the most, or we've finally hit that quota where we have surpassed the most within like a 1-year gap of overdose deaths. We could talk all day about how COVID could have exacerbated it, but that's going to be for a different webinar, definitely. Michigan overdose deaths. Get a drink. Let's see. This is looking from 2020 to 2022. So this is around between like 150 depending on the year, 180 maybe, and a little bit over it, given any point in time in the year. You can associate it with summertime, or, all those times that it's easier for people to be able to sustain their active use and not have like the negatives from being out in the elements or living conditions or anything like that get in the way. Those kind of things can change what each given month looks like, and how people decide. When they decide, it's a factor. Sometimes it goes into play on when people land in a treatment center. So I asked a lot of the respondents, or everybody. Most people believe persons addicted to opioids cannot be trusted. Now, this is what you guys thought that other people, when they thought of somebody that struggles with an SUD, that this is what they thought. Could they be trusted? Could they not be trusted? So we can see the data here, and it shows that there's a really high rate that what's going on out there is that people aren't really sure. So they just equate SUD and somebody having an SUD as being a negative, can't be trusted. Whether something that happened to them personally, something that's happened to someone they know or in the community, for whatever reason, that's just what's been put there. Now, whether we believe people can be trusted or not that are struggling with an SUD, the numbers are swaying completely different. And the reason why we know these things, and it's simply because we know the disease itself, we know what feeds it, we know exactly why it's being fed that. And we know that the reward response has a lot to do with it. Now, this is one of the bigger questions, I feel, that was asked in terms of where we fall into, like where the stigma really lies and what could be a bigger driving factor. So most people believed, when we asked all of the surveys, they think that most people believe people addicted to opioids, that they're dangerous. We can say, when we're out there, or when anybody's out there in active use, knowing that, this is a response to whatever's going on with our lifestyle, the situations we put ourselves in, that there is some dangerous aspects to it. There definitely are. Now, whether that's to be factual on somebody's character, that can definitely be argued. And in some instances, we can see why, people are just, it's very important that when it comes to danger, you got to look at it from both sides of the fence. Nobody wants to, walk out of a shopping mall or something and get robbed or thrown to the ground. But our inability to think clearly and to just like kind of do what we need to do. Because for somebody that's struggling with an SUD, it's more of like a fish out of water effect when you're seeking that next use. Fish out of water, they can't breathe. So for somebody that's looking to feed the disease, then for them, it's almost it's as bad as if they can't breathe. And, when we ask, do we believe that people struggling with substance use disorder are dangerous? The numbers are completely different. And looking at the regions, it does depend regionally where people are at, resources that each region has in order to help fight, the opioid addiction in the epidemic and all that. So there's a lot of factors that come into play that can be discussed. But these are all, or these two, the trust and the danger, those are two of the bigger ones that I wanted to share, simply because those are two of the bigger ones that it's very important just in your normal life, your day-to-day. There's certain, you have to have trust in order to, whether it's, get a job, or whether it's to purchase a vehicle and take out a home loan, just all those things. And then like we spoke about danger, like nobody wants to be fearful of walking into a grocery store, or if they leave their house unlocked, what could happen, or anything like that. So we're going to define stigma now. Stigma is a mark of shame or discredit, automatically put on somebody. It's telling you that you should be ashamed of this, and because of you, you know, we're going to completely discredit anything you have to say. A mark of disgrace that sets a person apart from others. When a person is labeled by their illness, they are no longer seen as an individual, but as a part of a stereotyped group. You really do lose your individuality when you get put into any kind of category, and it doesn't matter what kind of category that may be. And that's why that encompasses stigma. There's 4 different types of stigma. Public stigma, that's driven by the stereotypes, and stigma from within, self-blame, kind of telling yourself, had you not done this, then this wouldn't have happened. Had you not dated this person, or whatever it may be, Stigma from clinical providers, belief that treatment is ineffective. When that stigma takes place, it really does hit close to home, because healthcare providers are some of the few people we're able to access at the very beginning. We go in there, we asking for help. Could be a woman who's pregnant, could be somebody that's just looking to get guidance on where to go, or any of that. Stigma from recovery community. Some communities, they just don't have the resources to offer like any kind of education, any kind of enough doctors in the area that are willing to prescribe, just all that. So the recovery community is our main source of support. And when our main source of support is telling us that they don't agree with what's going on, that stigma is the same exact stigma we are getting from the general public. So it's a very big deal, and we pay attention to both of those. Nobody likes to feel like they're not a part of something, or that they're not respected, or loved, or any of that. Words matter when it comes to stigma. They determine how we understand and perceive the world. They carry power for good and for ill. Stigma is driven by pejorative words, the labels that are used to describe us. And this is not a matter of political correctness. It's more a matter of when you look at words like abuse, when you hear the word abuse, you're immediately going to equate it with something like, domestic violence or things like that. So some of those words have had to be removed from the equation in order for us to move forward and start breaking down some of people's beliefs in that. When we're hearing from people that, this person is abusing drugs, so that right there, that one statement, people are thinking that, okay, so if they're abusing something, then they don't deserve a second chance. They don't deserve, there's a couple of different things that can go into that. Changing the language of addiction. So we've got terms not to use and terms to use. Addict, abuser, user, junkie, druggie. Those are obvious. That's, we learned that in primary school, name calling. A better term that we've used is person, or that has been known to work, is person with a substance use disorder. Alcoholic, drunk, person with alcohol use disorder. Oxy addict, meth head, person with an opioid use disorder. Clean, dirty, that comes with the drug tests, negative, positive results. addictions, addictive disorders, and it's better to use addiction and substance use disorder. So this gentleman here, Gabriel Mate, he writes in this book, In the Realm of the Hungry Ghost, our difficulty or inability to perceive the experience of others is all the more pronounced the more distant these experiences are from us. Oops, sorry guys. Back one, there we go. The more distant these experiences are from ours in time, space, or quality. We can be moved by the tragedy of mass starvation on a far continent. After all, we've all felt hunger. We readily feel for the suffering child, but cannot see the child in the adult whose soul is fragmented and isolated, hustles for survival a few blocks away from where we shop or work. The way he says this is very, I guess, profound for me, because for a long time, the experiences weren't so widely felt. We didn't get from being at a point where, you know, the years of the 80s, the war on drugs, where people were getting these stiffer penalties and that, to all the way now where you know somebody that's experiencing this. You know somebody who has a family member that has possibly passed away from the disease. We all know somebody. We've all felt it. A lot more far and wide, and in some of those different corners of America that's maybe not so populated. So when we think about this saying, like, we do readily feel for somebody that is vulnerable, somebody that is like a child when they're going hungry and all of that. But if you think about it in the other terms of somebody that's living with a substance use disorder that now we know is a disease, they didn't ask for it either. So, you know, the child, they're not asking for them to be food insecure or any of that. So we should look at it the same way. And, you know, the world just has to watch kind of the wording that we use out there with things, because it does end up coming down to, when you use these words, they're already they're immediately thought of in a certain light, just because the way that their definition is. The illegal disease. This disease really became illegal in the 1980s. The war on drugs started, stiffer penalties. Right now, we're like struggling from 1980. Goes up to only to 2019, 10 times the incarceration in state prison and county jails, nearly 20 times in federal prisons, 50% federal prison population. The majority of these people are like low level with no history of a violent crime. It's possession charges and driving third offenses and things like that under the influence. We went from 22 months was the usual incarceration rate in the 1986 to now it's usually 62 months when you're incarcerated for a drug offense and different things that are surrounding that. In Michigan, you know, there's a lasting impact. There's going to be 7 years that a misdemeanor takes to get off of your record. There's going to be 10 years that a felony does. And within this time, it's affecting so many things. 7 years for a misdemeanor. We know that some places they won't let you in, like living in that, because there are low grade or high misdemeanors out there. They won't let you in. So there goes your housing right there. You know, if you don't, we know that stability is key to being able to progress in our remission. And when we don't have stable housing, we don't know where we're going to go. Then we find ourselves accepting precarious sleeping situations and living situations. You know, when you're not housed, you're not trying to seek employment. You're obviously not going to try to go out there and get student loans. So with these being on our records for so long, you know, it's a domino effect. It's a sure domino effect. A look by region of offered diversion programs. So number 6 is going to be areas that are, there we go. So offered diversion programs. Number 6 is going to be just like those non-specified areas, but this is a look of each county and if the counties are offering diversion programs. That way we're not dealing with such a high rate of people that are being incarcerated and for longer periods of time. Diversion programs usually offer a lot of resources so that we can get people into treatment. We can get like the drug testing that's required done. I know some have been knowing to pay for the drug testing, help with job finding. So if you're looking at these numbers, you know, the different regions, they're kind of the same, but region 3 is Western for whatever reason. You know, it's down a little bit lower than what we're seeing in some of the other areas. So why does addiction treatment look different? Drug addiction is ranked number 1 and alcohol addiction ranked number 4 as the most stigmatized conditions internationally. Common belief that individuals should be able to simply stop using problematic substances. Abstinence-based programs are often viewed as the preferred treatment. When we go into an epidemic that has hit people so hard as this has, abstinence usually was, but they have had to try to like grow and bloom around what the overall outcome, I guess they know would be if they didn't. So AA was started before anything else. Then NA came along. But now there's so many kinds of treatment out there. There's Dharma and there's smart recovery. Plenty of options for people to kind of see what works for them. Common belief that individuals should be able to simply stop using a problematic substances. That comes from stigma right there. That comes from lack of knowledge, lack of education, lack of resources, going out into just the general community and to our own recovery communities. So comparing the relapse rates of somebody that relapses and say somebody with type 1 diabetes, high blood pressure, asthma, these are all known to be diagnosable diseases, every single one of them. The relapse rates are the same, are pretty close to the same. But what's not the same is the treatment and how each treatment is done. Going in, somebody with diabetes, if they're found laid out on the side of the road or something like that, they're not going to be walked past or like looked at as somebody that is struggling with an SUD and, you know, maybe might have something around them that's showing signs that that's what this person, you know, is going on, is that they're probably just passed out. Asthma, same thing. It's not going to be treated, you know, any differently, or it shouldn't be treated any differently than somebody struggling with an SUD. And it is treated differently in a lot of different senses. Even when it comes to going to the doctors, a lot of doctors can treat somebody for asthma and write them their prescription. But we know when it comes to, say, if we're trying to treat somebody with an MOUD, that's not the case. We had to get through waivers we had to go through first, and then there was a cap on how many people you could treat, and you know that it's not comparable in terms of how treatment is viewed and how it's given. And so MOUD in our community. So the goals of using medications for opioid use disorder, this is going to be the same when it comes to if you're not going to use an MOUD. When it comes to recovery in general, you're wanting to prevent overdose deaths. Simple as that. That is the number one thing, because that is the biggest, and that is the only thing that there really is no coming back from. Jails, institutions, yes, you may be able to if you don't get, you know, a harsh life sentence or something, but prevention of the death rate is really what is the factor that there's just no coming back from. So all treatment centers are definitely trying to get the help out there that people need, and that's the number one goal. But for an MOUD, they reduce cravings and withdrawal symptoms, block the euphoric effects of other opioids, restore the normal reward pathway, interrupt the cycle of seeking, using, and recovering, and your ability to recover from drug use. When you interrupt that cycle, that reward mechanism, and you interrupt it long enough where you're starting to take on another cycle or another hobby or form a new habit, then it interrupts that. And MOUD is known to give you that time to be able to start getting your life back on track, and, you know, not dealing with, you know, the cravings and different things that come with it. And then this will improve rates of engagement with treatment. If somebody's not too busy out there, I guess, running after their addiction and seeking their addiction and things like that, then they can engage in treatment. But if they're not able to get there, then an MOUD could always be a viable option. There's a high relapse rate out there as it is. So we need to make people feel comfortable enough to where they can go to a doctor and ask to be put on an MOUD, as opposed to just trying time and again. There's never any guarantee that time and again is going to happen. So when we asked you guys, how open do you feel your recovery community is to MOUD as a pathway to recovery? Region 2, I would want to say, is probably the highest in terms of they've got enough resources and surrounding just education, different things like that, in order for them to have a more open community. That's what the data is showing. So there's a lot here, though. If we're looking at 59 respondents and we add the numbers up, can't really do it with percentages. I mean, it's still pretty low out there. If there's not enough education out there, then how are people going to know that this isn't just the normal saying that we know has been used to hold people back from getting on an or utilizing an MOUD? You know, if you're doing that, then in your people don't have enough education, then you're not going to seek it out. The community's not going to support it, and the resources aren't going to be there. So this shows where each region is at. So region, and whether your belief is MOUD should be more widely available. Region 1 at 16.7, region 2 again at 33. The green one represents regions that are non-specified. So MAT and MOUD treatment effectiveness. There's been studies done now because it's been out there for long enough where you can kind of see along a continuum and start to chart things out and graph things out and see what works and what doesn't. But we know now that, you know, it helps improve HIV and Hep C outcomes. An increased likelihood that a person will remain in treatment. And then recent evidence suggests cost-effective and it improves your quality of life. It reduces the overall overdose death rate and reductions in opioid use and other substance use and misuse. Medications are the most effective treatment for an OUD. Without medication treatment, patients have higher rates of substance use and overdose. It's like a 50% higher rate that somebody is going to go out there and relapse or overdose if they don't decide that one way may not work. You know, I feel comfortable enough with my surroundings and my community, loved ones, family, to maybe go out there and ask for help. So the gaps between the science and care. There's a profound gap between the science of addiction and the current practice. This is a result of decades of marginalizing addiction as a social problem rather than treating it as a medical condition. For a very long time, it wasn't considered a medical condition. It wasn't even defined as one. It was thought of as a social problem. Much of what passes for treatment of addiction bears little resemblance to the treatment of other health conditions like we talked about before. You know, you're not going to walk in to talk to your doctor and, you know, you're wanting to get your medication for your diabetes and you're not going to get asked if you can drug test, say, to prove you're taking that medication. So the treatment, there's vast ways that people go about seeing the differences in treatment when it comes to what we have known our whole lives to be a disease versus what we are now starting to get the broader community to understand. So SAMHSA and ASAM have recommended switching from medication-assisted treatment to medications for opioid use disorder. MAT implies that medication plays a secondary role. When you do that, then it gives you something that plays a first role. And then the question comes into play, well, why can't you just? And it's not always that simple. So with this, medication is the key to treatment when it comes to, you know, if you're going to use an MOUD, nothing else has worked. It is proven that MOUDs out there are the main key to that person's treatment. Other things have been tried, and you know, if you weigh the risks versus benefits and all of that, it's life or death. MAT is still used to refer more broadly to medications for addiction treatment, but that's more in like a broader sense, like it said. So addressing stigma. Does language really make a difference? I mean, I want to think that everybody has felt stigma in some sense of the word in their life, in some area of their life. You know, it's not just people struggling with SUDs that are stigmatized and put into a certain, you know, category or box or any of that. There's all kinds of stigma out there. But when we're talking about substance use disorder, this is something that we don't know a lot about, or we know plenty about, but we don't know how to get it broadly, where a lot of people that maybe don't have a vested interest, family, friends, things like that have passed away. So how do we get it to where it's reaching all corners of our life, social life, all of that? How do we get it to where it's far enough? help with treatment is something that regardless of the past, everybody should get. Adequate pain control, caring conversation and relationship building, appropriate and safe treatment, a feeling of mutual trust and non-judgment. So you're walking into your doctor's office, if you're feeling judged, you're not gonna really be open with them as much as you would as if you had that feeling of trust. So regardless of the past, the stigma that sometimes, whether it's, subconsciously or not, that stigma, it's gonna show in some sense. I've heard of people walking into their doctor's offices and they get handed a copy of their paperwork, showing, I guess, what some of their diagnoses are, and it would say right on there, drug abuse. They no longer see that anymore. That's because we're starting to get to the point where it's not us having to really teach just the doctors. People are learning these tips and stigmas and all kinds of things, just all of that. You're starting to learn it now as you're going through school, and it's being brought out into the community, which is making an impact on what you're starting to see in the doctor's offices. And, we could say the same for even some police departments. They have enough education there before they put somebody out in an active role as being a patrol officer, and it's completely different. When they've got the tools, when they've got the education, then that's when stigma can start being combated. So addressing stigma in OUD treatment to achieve a lasting change. Expanding evidence-based treatment, reducing the harms of ongoing opioid use. People with OUD should not be refused medication if they refuse psychosocial interventions. Access to sterile injection equipment to reduce secondary transmission of HIV and hepatitis C. So a lot of this stuff is going along with harm reduction. Expansion of overdose education and naloxone distribution. And this is to reduce fatality rate of an opioid overdose. And then changing the language that we're using around people when they're being diagnosed, when they're being treated, and all across the board, being able to change the language where you're not using things that in the past, if it's had a negative connotation for this, then how could it be not thought as having something negative to it when it comes to referring to something going on or something happening or with somebody struggling with an SUD. So that's why the words, they absolutely matter. Harm reduction, it's a known fact that if you've got enough harm reduction out there where you're able to get access to clean, where you have access to like clean like vans, and they've got needle exchanges and things like that, and have access to clean injection equipment, it's known that that's going to slow down rates of Hep C, HIV, and some of those other diseases that need the same kind of treatment that SUD would need. So indirect interventions to address public and systemic stigma. If we address like the larger institutions, or we go about it more in like a way that we're getting it out to like mass media, social media, different things like that. We know that mass media, social media, they're on an upswing right now. Everybody's hopping on board when it comes to different things, different apps, different ways to communicate with the outside world. So getting all that, getting what we need out there to those kinds of resources would definitely help us move through this. And also like broadcast media, the news and things, when you're hearing things on the news and you're hearing, bad things, somebody getting robbed, somebody getting, I don't know, somebody getting their child taken away because they, fell asleep or something at the wheel, then when you hear just that, it's going to be negative. Those are things that scare most people, to whether it's happening to them, happen to someone, it scares them to think that, this is what's going on around them. So if we're broadcasting something better than just all of these negative things that happen in the life of somebody struggling with an SUD, and we start broadcasting more things like, maybe how somebody was able to go from actively using every day to being in remission for a year. What was it that they did? That they use an MOUD? Just broadcasting things like that, having TV shows. They've got all kinds of different shows out there for that. And those shows make an impact when it comes to stigma. And there's just all kinds of ways out there. So, reaching far and wide and finding what it is in your community that will help break any kind of stigma, so that people aren't being held back from doing what they know they need to do, but not wanting to ask for the help because they don't want to feel like they're doing something wrong, or they're any of that. Being able to ask for that help and finding something in the community that helps with that is definitely a good way, because when one person turns to 2, turns to 3, then before you know it, 10 years passes and something is finally considered a disease as opposed to just a moral issue. So does anybody have any questions they would like me to answer? I do have about 10 minutes left. You can put it in the chat, or you can unmute yourself if you'd like.
Thank you, Katrina, so much for this presentation. It was very good information, very helpful. Does anybody have any questions for Katrina, or any comments? Katrina, the question is, I was just wondering how many questionnaires went out for the 6 regions.
For the 6 regions, there was about 100, I think it was 120, somewhere in there, that had gone out, and we had gotten 59 respondents. There was about 30 bounce backs with the emails, meaning that somebody might have switched jobs, changed emails, something like that. So if you take 30 away from the 120 or so, about 90 actually made it into a inbox of some form, and 59 responses is what came back.
He had $2 balance, so he's got $22.
Oh, please make sure you're muted. Thank you. Where was the survey sent that you referenced during the presentation?
The survey was sent all throughout I think it's 5 regions in Michigan. There's northern, western, the Metro Detroit area, and like central mid Michigan. So there's different regions. There's a slide in here that you guys can look at to kind of reference, because it was all of Michigan, but to kind of reference how the regions are broken down, and then using, is this an urban area, heavily populated, what kind of area it is, to kind of tell what the data was showing based on that.
Okay, thank you. And then the next question is, how do you feel like stigma affects women in addiction who are trying to get their children back from the court system?
Well, we know that when we're dealing with stigma, there's laws that were put into place previously that didn't work. Now, when you're walking into a situation where you're having CPS, the police, anything like that, looking at you and looking at you hard, it's a matter of if laws are up to par with what we know to be true with addiction. this is a disease? Are they treating you like you have a disease when they're making, I guess, case plans, they would be called, for people that have had their kids put in foster care? I mean, there's a lot that could go into that. That could be a completely topic on its own. But women are also more vulnerable to not going in and getting the help they need sooner, because they are the caretakers of their children. And so when you're wondering, like, you know, what's the chances of somebody, there was a number, I think I'd seen it the other day, there's like 50% or something like that currently shows actually gets their children back. And that's because of a law that was passed in 1997. And it's like the American Families Law, something like that, some kind of legislature. I can't quote it, but definitely that law, when it was put into effect, it made it to where the people are no longer getting their kids back at a higher rate than even what they were back in the 1980s, when we were fighting the war on drugs and people were getting sent to jail quicker. So there's just a lot of factors that can go into that.
Katrina, Susan asks your ideas and thoughts about impacting stigma within the recovery community. What are your ideas and thoughts about impacting stigma?
So in a perfect world, everybody would, I guess, everybody would not have to like feel that pain of having a loved one pass away when we're talking about the recovery community. But because everybody has felt that, if we can just get people to understand that the science is there in terms of how MOUD can save someone's life, versus how if they're sticking with the old, you know, AA is the best path, 12 steps, that's it, you know, something like that, and nothing else, then, you know, the death rate's going to be higher. So if people can take a step back and think of all of those people that have passed in and around them, you know, recovery communities are the communities that are hit the hardest, because it's usually, you know, somebody's friend or boyfriend or girlfriend, because it is a community. So, you know, just if getting people to really take a step back and look at the science that's there, and just it's something's got to change. Bringing more people maybe to the forefront and discussing how they were able to succeed, you know, with their remission by being on an MOUD, and what they were able to get back in life. All of those things I think would be helpful. And it's a matter of talking about it and, you know, respecting everybody's thoughts and feelings on it. But, you know, everybody's got to hear somebody out, and having more people come out there talking about their experience with MOUD, I think would be really helpful.
Thank you. Thank you for all your questions, everybody. Thank you so much, Katrina, for speaking to this issue. And it's really nice to hear from someone with lived experience. Very, very grateful. Thanks, everybody, for attending. Please watch your email for, we'll be sending the PDF for the credits, and we'll also be sending the slides within the next couple of days. Thanks for attending our webinar today, and have a good day.
Thanks, everyone.